So I was wondering if you could tell us first why you decided to enter medicine.
Why I entered medicine?
Yeah.
I first got the idea of going into medicine because of my uncle. My uncle, Thomas Hunter, was a family physician in Shrewsbury. He was my hero, and I tried to follow in his footsteps. Of course, later on, I became interested, and I realized that's what I wanted to do. I wanted to contribute something, and contribute a good way is by being a physician and helping people.
So initially it was from having your uncle as a role model.
Yes, yeah. Well, that was back in the Depression, and doctors worked hard. They didn't get paid very much then, a couple of dollars for a house call and stuff like that. So a lot of free medicine that they performed too. Yeah.
So where did you attend medical school?
Did I go to medical school?
Yeah, where did you go to medical school?
Oh, Boston University.
BU. What year did you graduate from BU?
1944.
Do you remember approximately how much it costs to attend medical school?
I think the cost is about $600 for tuition for a year. I'm not sure, but I think it was in that vicinity. It wasn't thousands anyway, it was hundreds.
Yeah. Did you have to take out any loans or anything? Or were you able
Yes, I did.
You did?
Yeah. It was a government loan. And then after I graduated, took my internship, went into the service, took a residency, came out of the residency, and who do you think I heard from right up? One of the first ones was the government. Where's that loan and the interest on the loan? I thought maybe they'd forgotten about me.
You were hoping.
Yeah, well, I was very willing to pay it back.
Yeah. How do you think that cost compares to the cost of medical education today?
Taking into account inflation, I mean, it's way out of proportion. I mean, today the tuition is so, it depends upon the medical school. If you go to UMass Medical School, it isn't so bad. But your private medical schools, it's just out of sight. I can see where the young people in college have to plan and work in advance to set up their financial backing. And I think that when I graduated from medical school, I had a loan, but it was nothing like the loans that the students have today. The loans today, I understand, is up in the thousands.
Hundred thousands.
Yeah.
Schools.
Yeah, that's what I understand.
Yeah. I'm lucky to be going here. I'm a second-year student.
UMass is one of the greatest bargains in the country.
Yeah. Can't really beat it.
Yeah.
So after you graduated from BU, you did your internship?
Yes, I interned here at Worcester City Hospital, a general rotating internship. At that time, the three best internships in New England were Worcester, Providence, and Hartford. And we started working towards getting an appointment about our sophomore year for the hospital we wanted to train at. That's quite a change today.
Yeah. How did you choose your specialty?
I decided to go into general surgery, and I went into the service. And I was fortunate in that I was in a hospital all the time I was in the service. The last 18 months I was in the service, I volunteered to work in obstetrics, obstetrics and gynecology. But I still wanted to go into general surgery. So when I was being serviced out, I made applications for residency in general surgery, and I would have had to wait 1.5 to 2 years before I could get an appointment. Whereas since I was in the service in Baltimore at Fort George G. Meade, Station Hospital, I became known, or I began to know a lot of people in Baltimore. And a group of physicians said, when you check out of the service, you want to go into OB/GYN, we can give you a job immediately. So that's why I went in. I felt it was a surgical specialty anyway, and there's a lot of good surgeons and a lot of changes are going to take place. So that's how I went into.
Any regrets at all?
That's what?
Any regrets?
No, no, absolutely none. No, it's a great specialty, and it has broadened so much. When I first started practice, it was more of a mechanical, like surgery, mechanical specialty. But over the years, there's been such tremendous progress in all areas of obstetrics and gynecology and oncology and endocrinology. It's unbelievable. To be able to do everything in OB/GYN for one person is impossible now. That's why they've branched out into to gynecologic oncology and reproductive endocrinology, fetal maternal medicine.
So did you do your residency down in Maryland?
Excuse
Did you do your residency in Maryland, or did you come back to Massachusetts?
No,
for your residency?
I went to Baltimore. It was when we were getting out of the service. There were so many people. 75% of the doctors being let out of the service were applying for residencies. So, in fact, I went to Framingham Union Hospital and spent 6 months in general surgery there. Then I went into the residency program down in Baltimore. So I had a rotating internship, training in general surgery, and then OB/GYN, and then GYN oncology.
It's quite a mixed bag of training at the beginning, huh?
Yeah, for those days it was pretty darn good training.
When you were enlisted in the service, did you see injured soldiers at all?
Could I say what?
Did you see any injured soldiers at all when you were enlisted in the?
Well, in the hospitals. I was in the hospitals. Although most of the hospitals that I was in did not handle casualties. They handled sick soldiers and soldiers going overseas. They had to be examined before they left. But I was in general surgery for a good number of months, and then there was an opening in the obstetrics and gynecology, so I thought I'd try that. And so I was in that program well over a year. So I saw a lot of OB/GYN, believe it or not.
All the families of soldiers on the base?
No. I lived in a private apartment.
So when you first began practicing after residency, did you come back to Massachusetts?
I came right back. Yeah.
And when did you first start practicing?
I opened my office September 1st, 1949, and I retired October 1st, 1901. Yeah, I mean, 1901. It was just 50 years practice. Yeah.
So you had quite a long career.
50 years.
And did you stay in the same area over your entire practice?
Same area.
And where were you? Were you in Worcester?
I was right in Worcester, yeah. I was born at Memorial Hospital, and I practiced at Memorial Hospital. I was at Memorial for 25 years, and active not only in the practice, but in the teaching aspect of it. And when the medical school was built, I was invited to be the founding chairman of the Department of Obstetrics and Gynecology. So the rest of my career I spent up here teaching and research.
So what were some of the reasons that led to you choosing Worcester?
I liked Worcester. I was born here. I went to all the public schools. I went to college. I went to Clark University. You know, I like Worcester. I still think it's a great city. And the next 25 years, I imagine, will grow a lot bigger, and the airport will expand, and it's changed tremendously in the last 50 years. I can't imagine what it will be 50 years from now.
What was a typical day like for you when you first started practicing?
When I first started, I spent a lot of time cutting lawn and things like that. But I was fortunate. I built up a practice very rapidly, and that's because I came from Worcester. I had a lot of friends and acquaintances in Worcester. And I had an aunt and an uncle who were both family practitioners out in Shrewsbury, and then a lot of referrals came from personal friends. I had one personal friend, an Armenian fellow, and I had a big Armenian practice. I had a very close friend that ran a grocery store down in Quinsigamond Village, and every woman that came in there with a GYN problem ended up in my office. So I had a big Swedish practice.
So it took you a little while to build up your practice?
Yeah, I'd say 2 years. After that, it really expanded. My main interest was in gynecology, and particularly oncology. And the first 20 years I did obstetrics. After that, I limited my practice to gynecology, and then eventually I limited to gynecologic oncology. And that's when I came up to the medical school, my practice was limited to the oncology.
What sort of changes did you see in the field over the years?
Enormous, unbelievable. When I first started practice, for example, the Pap smear was just coming on the scene. It had been discovered, many years before that, but as far as being used practically by practitioners, it had just started, and we didn't trust it. When I came into practice, if you had a suspicious cervix, you'd not only take a Pap smear, but you'd take a biopsy. You'd always supplement it. In fact, when I was down in Baltimore at the Hopkins Cancer Clinic, it was Cancer Detection Clinic, and there was a group of us that were surgeons, ENT people, internists, gynecologists. Every Wednesday afternoon, we would each examine in our specialty all these patients. And in gynecology, we took a Pap smear on every patient, and we did 4-quadrant biopsy on every patient. And so that when I came into practice, it wasn't the standard just to take a Pap smear and make a decision on it. It was years later that it was established that the Pap smear was an accurate way of diagnosing cancer of the cervix. And then in cancer of the cervix, that was the era where they formed the idea about carcinoma in situ, or pre-invasive cancer of the cervix. Nobody knew how to treat it. So we started treating it with a modified radical hysterectomy. And then we soon realized that that was too radical for that diagnosis. So then we started doing colonizations, electrocone or scalp cone. And then later on, the laser came into play to treat it with laser. So we went all the way from a modified radical hysterectomy down to a colonization of the cervix. And I think in general, all of medicine there has been a tendency to decrease the radicality of cancer operations, like in the breast. I mean, it was routine. Radical mastectomy was the treatment for cancer of the breast, and you know now how that's been reduced down to lumpectomies and radiation. In the treatment of cancer, the cervix, that was the era where Dr. Meigs in Boston had popularized, again, the radical Wertheim operation. And so that's when we started doing that on suitable candidates. But it soon became clear that that wasn't any more curative than radiation itself. So we limited the patients that we did the radical hysterectomies on. Young women, and we could preserve the ovaries and they wouldn't go through the artificial menopause. And that, shortly after that, the era came into play about the size of the incision. When I was in training and practice in the beginning, the bigger the incision, the better the surgeon. That was the sign of an experienced surgeon, was a big incision. Now, of course, we're down to doing laparoscopies with just a 2 or 3 centimeter incision at the most. And originally, when we did laparoscopy in gynecology, it was for tubal ligation. But now, as the years have gone on, it's used to do vaginal hysterectomies, abdominal hysterectomies, oophorectomies, even node dissections, radical node dissections being done with a laparoscope. So and of course, then other specialties picked up on the laparoscopy. But it was gynecology that persisted and realized the potential of it. And now it's in every specialty. Even orthopedics, the knee.
That's amazing.
You know.
Did you perform laparoscopy surgeries yourself?
Did
you perform laparoscopic surgeries?
Yes, we did. Yes, I did. Yeah. Mm-hmm.
Was it difficult to learn the techniques involved, or?
Well, I went away postgraduate course and watched them, and then came back and did them myself. You know, there was a period there where all of the gynecologists were learning how to do laparoscopies. So that eventually all the young graduates were better trained than the older gynecologists. Because I spent 4 years in a program doing laparoscopies. But the same thing was true of colposcopies, which is an instrument that enlarges the cervix so that you can see if there's any abnormal areas. And that was over in Europe long before it came here. You know, I know I didn't have much faith in it. I went away and I took a course in it and came back. And we didn't have any such thing as a colposcope. But the eye surgeons had a magnifying lens that they examined the eye with, and I took one of those at Memorial Hospital, got an old one from the ophthalmologist, and every patient for the next year, when I was on schedule and had time, I'd swing this instrument over and study the cervix and do biopsies. And that's the way I learned. Of course, a lot of the things that we do, we teach ourselves. If you've got the basic training and the knowledge, you can do that. But it was still a good many years in this country before it became popular to do colposcopies. Now, almost every gynecologist's office has a colposcopy.
And I'm sure there were a lot of drug changes as well, like with chemotherapy.
Oh, yes. Yes. 1955, the first paper was published on the use of methotrexate in choriocarcinoma. And choriocarcinoma, when I was a medical student, was 100% fatal. it's virtually 100% curable now with just chemotherapy, mainly methotrexate, even without any surgery. And these women retain their reproductive function as well. So that was the beginning, the dramatic beginning of chemotherapy. And then the next step was to use it for ovarian cancer. And when we first started using that, at the time of the hysterectomy, we would put a chemotherapy agent named Thiotepa, and you put it in the peritoneal cavity and then close it up. And that was the beginning of the intraperitoneal therapy. But now, as the years have gone by, there have been many drugs that are effective in ovarian cancer. Most of your drugs are platinum drugs and Taxol. In 75%, you get a complete remission, to go back and do a second look, and there's nothing there. But unfortunately, it's not lasting. In a small percentage of cases, it's curable, but in most cases, it prolongs the patient's life, and it's a good quality of life. But we still need another agent, because now with the surgery, we do what they call cytoreductive surgery, which means that we spend a lot of time removing every bit of cancer that we can, and then follow that up with chemotherapy, and then do a second look operation if you've had a complete response. Find no residual cancer in there, microscopic or macroscopic, yet 50% of those patients will still be dead within 5 years. So we got to a point where a huge amount of tumors, all the way down to 0, but we can't make it lasting, and that's what we're working on.
You mentioned you were the first chair at UMass
Yes,
in OBGYN.
yes,
Was it difficult to start up a department
yes,
from scratch?
yes, it was. Yeah. The thought down in Boston was that great big white elephant they got in Worcester, what are they going to do with that? They don't need that. And we didn't have very much cooperation from the physicians in Boston. But yes, what my thesis was here in Worcester was that the main obstetric hospital would be Memorial Hospital, because they already had become established as a perinatal center, and that the tertiary gynecology, the oncology and endocrinology, and the radical gynecologic operations would be done up here. So right from the very beginning, UMass and Memorial were together in the specialty of obstetrics and gynecology. But there was still a lot of competition. It takes many years for a community like Worcester to be geared to a university program. And it's getting there. It's not there yet. There's still a long ways to go.
Yeah.
But in general, the obstetricians and gynecologists were very cooperative, very helpful. Most of them were not interested in taking care of cancer, invasive cancer. So they understood why we needed a center up here. And we also had to include a lot of other hospitals, to be fair. If they wanted a teaching program, I gave them the opportunity to. That would be Memorial, St. Vincent's, Hahnemann, Berkshire Medical Center, Framingham Union Hospital. They were all part of our program at the beginning.
So it seems like you really tried to work together with the other hospitals.
Yes, yeah. There was the problem, of course, that the hospital didn't want to lose any patients, and they wanted us to do a radical surgery. And you can't do that. I mean, if you're going to do radical surgery, you have to have a team and the facilities. What we call a university program that would include not only treatment but research and education. So you see now it's boiled down actually to just 2 hospitals in Worcester. And, obstetrics is done mainly at Memorial Hospital, Memorial and the new hospital downtown.
What do you think's led to that change? From going from 7 or so hospitals down to 2?
Well, it took a period. It was just, what, 2 years ago, UMass and Memorial merged. So I'd say from the beginning, when I first came to Worcester, there was a program going to do away with a lot of obstetrics in general hospitals. So it's a period of 50 years that's been going on.
So it's been a constant thing. It hasn't happened overnight.
Oh, no. You have to readjust your thinking. You know, if you're doing obstetrics at one hospital and then suddenly they want to close that down, you got to go to another hospital. That's a big change. And hospitals fought it. I mean, they felt that obstetrics was the bread and butter of a hospital. If a woman has a baby at a hospital, that's her hospital, not only for herself, but for her children and her husband. And that's what they promoted. That's why it was hard to regionalize obstetrics.
So what were some of the major difficulties you faced getting a OBGYN department off the ground at UMass?
A lot of problems. Mainly disrupting the obstetrics in other hospitals. You see, the hospitals feel that obstetrics is a feeder for their hospital. If a woman has a baby at a hospital, then all the rest of her life, her family would go to that. That's their hospital. But if you take away the obstetrics, you lose that feeling amongst the patients. So that's a battle. And then some of the doctors battled it too, because they'd been practicing at a particular hospital all their lives in obstetrics, and they didn't want to have to go to another hospital. But as the program grew and the education grew and the hospitals got involved in teaching, that all helped to bring it together. It's never easy to merge, you know.
We're seeing that now.
Yeah. Oh, yeah. Well, I think UMass Memorial will be another 10 years before we're really merged. You know, before it's a nice hospital, nice university hospital with the ancillary hospitals. And of course, the way the government is working and getting more and more into medicine and into controlling medicines, it's going to make it very difficult.
And that was my next question.
Yeah.
How did managed care change your ability to practice medicine?
It changed. What you mean, HMOs?
HMOs or Medicaid, Medicare?
Yeah, they all came about. As physicians and as the Massachusetts State Society, we weren't keen about HMO, about Medicare, because we'd been taking care of those patients for many, many years, and if it was a widow who was on Social Security and she needed a major operation, we'd never charge. I mean, that's part of being a physician. And then, of course, we had, if the patients didn't have insurance and were on welfare, those were the patients that made up the service and those are the patients that are interns and residents, excuse me, trained on. So you can say in a way we were going to lose that whole segment of sick patients for training purposes because when those programs came in, they wanted to do away with the wards. Like at Memorial, we used to have 2 big wards. The politicians felt that every patient was entitled to at least a semi-private room, so that's why those wards all disappeared. I have difficulty with the principle of the HMO because I think it creates a conflict of interest. I mean, the HMOs were set up one purpose was to teach physicians economics of medicine. And the way that it was set up was that the more you keep the patients out of the hospital, the fewer tests you do, the fewer x-rays. It's going to help the HMO financially. And if doctors do that, at the end of the year, they will get like a bonus. And to me, that's a direct conflict of interest. Because then the doctors are working for financial purposes as well as humanitarian purposes. And that's when the idea of service patients disappeared. Like here at UMass, there's no such thing as a service patient. They're all private patients. So we had to adjust to be able to train, particularly surgeons. It's still a problem. And of course, where the programs have gone on to shorten the length of stay in the hospital and admit patients for major surgery in the morning and do it later on, it makes it very difficult to teach residents under those conditions. So education has changed dramatically.
It's an interesting perspective that managed care has changed education a lot.
Yeah. Yes. HMOs, have served a purpose that has changed medicine completely. But there are still many patients that are not in HMOs. And I personally feel that if you can afford it, to have health insurance outside of an HMO is the best. Then you can pick your physician, you can pick your hospital. You have more direct contact with the financial end of it. But HMOs keep growing more and more. And they have created such a big portion of health care that Congress, the United States Congress, is spending a lot of time on health care and debating what should be included. It's ridiculous to me that the United States Congress has to discuss and debate and make a decision for doctors as to how long the patients will stay in the hospital. Like, about a year or 2 years ago, Congress passed a bill that obstetrical patients must stay at least 24 hours in the hospital. I mean, imagine the government making a decision like that. There are more and more decisions that are made by HMOs, insurance companies, and the government. And that's one of the reasons why they're now discussing Bill of Rights in Congress. We shouldn't have to do that. Medicine, those important decisions should be made by the physician.
Do you think physicians have lost some control in the care of their patients?
Oh, yes, lost it. Lost it to the government programs and to the HMOs. We'll never get it back, I'm afraid.
You don't think so?
Well, I think the tendency is more and more towards a socialized system. national health system. But when I was a medical student like you are now, we were worried about it then. The socialized medicine was a big problem. We were all frightened that that was going to happen. Well, it's happened to a certain extent, not completely, not like it is in England.
Do you think Medicaid and Medicare have improved patients' access to getting health care?
I think so. I think so now. Because the whole philosophy is changed, and the right to have good health care, it's sort of been made a right for the patient, not just to have it, but I think the feeling is that every American is entitled to good health care. And I think they've been able to do that with the Medicare, with the government controlling it. Well, of course, all the problem is the enormous expense that health care is for a family today. Particularly as you get older, it's unbelievable. I went to the drugstore a couple of days ago, and I had to get a tube of medicine. It was about like a tube of toothpaste, and it cost $25. And I said, well, I think my insurance would cover that. They said, well, we've already taken out your insurance coverage, so I don't know how much that tube cost. Yeah. But it's unbelievable.
I think that's kind of another problem in medicine is pharmaceutical companies.
Yeah. Yes. I know what this problem, but you can buy drugs a lot cheaper up in Canada than you can down here.
Yeah.
That's ridiculous. Look at all the trouble the patients have to go to get their medicine.
Yeah. When did you get married?
September 10th, 1944, the day after I graduated from medical school.
Wow, good timing.
Yeah, well, good timing, because in the internships then you didn't get paid anything, nothing. So my wife worked, so that helped out. But there's a big change right there for the residents, interns. They get a pretty good living wage while they're training now. But the only thing even when you get to be a resident, start out at $25 a month. By the time you're chief resident, you got $75 a month. And of course, most of us getting out of the service after World War II would never been able to do that without the benefits of having been a veteran, the Bill of Rights for the veterans. So most all of us residents, it was, I think it was, they felt you were entitled to $200 a month. So if you got $25 a month, then from the government you got the balance to make up the $200.
Did you have any children as well?
Yes, yeah. I have 4 children. Yeah. My son, who was born down in Baltimore, he's an obstetrician gynecologist in Worcester.
So you followed in your footsteps. You followed in your footsteps.
Yeah, he told me he wasn't going to. When he was a teenager, he told me he's not going to be a doctor. So I said, that's fine. You follow your bliss. You do what you want. He ends up going to the same medical school, taking his residency in Baltimore, and then coming back to Worcester to practice.
Wow.
Yeah. Then
Future repeats itself. Past repeats itself.
Yeah, well, he was the 3rd generation to go to BU Medical School. See, my uncle went to BU Medical School, too.
Wow.
Yeah.
Was it difficult raising a family with such a busy professional life?
Yeah, yes, it was. it was my wife that really raised the family. She was the boss in the family, and I just did what I was told, you know. But I pitched in as much as I could. But I had a very, very busy practice, and then I was interested in teaching, and I started the residency program at Memorial, and then when I became chair up here, there was a lot of traveling to do, which I loved, but by that time, my kids were all in college or had graduated from college. But if I have any regrets, it is that I was too busy. I wished I had spent more time at home with my children. So when I was home, we always did something, you know. In some ways, you had more attention with your children in that way than if you're there all the time and just don't bother. So my wife planned a lot of things when I was going to be off. And of course, in those days, we practiced as a solo practitioner, and you had to get someone to cover your practice while you were gone. And then the idea of group practices came into being. And I went in with two other doctors, Dr. Albert Jones and Dr. Robert Bennett. Three of us practiced together for about 15 years. It was very, very successful. So essentially I was off 2 out of 3 nights and 2 out of 3 weekends, so that made it a lot easier for my family. But a physician's wife has to be dedicated to the practice of medicine too, because things change so fast. I can remember getting ready to go on a vacation. I had a patient in the hospital. I couldn't leave until she had delivered, so we would sometimes delay the family. They'd be all packed and all ready to go, and they have to wait until that situation was cleared up. But that's why I say it's a big adjustment for a woman. She must realize that there's a sacrifice.
I just got married in June.
Oh, did you?
So
yeah. Well,
my wife's very understanding. So
yeah. What does she do?
She's going to school to be a guidance counselor.
Oh.
Going for a master's degree, and she's working as well.
Mm-hmm.
So.
Where is she? At UMass? Or?
Nope, she's going to Fitchburg State.
Pittsburgh State?
Fitchburg, yeah.
Yeah.
She's great.
Mm-hmm.
Do you have fond memories that you look back on?
My family background?
Either your family or practice, fond memories?
I have a lot of fond memories. I wouldn't know where to start. I've had so many in private practice and in academic practice. I enjoyed traveling when I was chair. I enjoyed going to the various states and countries and presenting papers. I enjoyed that very much. That's hard on your wife, academic medicine, unless she travels with you. And if you get 4 kids like we had, she can't travel with you. But I enjoyed meeting all these other physicians all over the world. It was a great experience. And it was quite a challenge, and well, still very exciting that all the residents that graduated during my tenure as chair, that they go out and practice, and you see them at meetings, or some of them we kept close contacts with. So this whole group of people, you sort of have a personal responsibility that they do well. But I've had to, particularly in the subspecialty of GYN oncology, the last 25 years of my practice, that's a difficult and not a happy specialty. But anything that I could do to help patients got cancer, and unless you do something, they're going to die. so that you not only try to cure them, but you try to give them a better quality of life. That's one of the most important things. And over the years, I had a lot of patients with gynecologic malignancies that get cured. Of course, a lot of them didn't get cured, but some of them dramatically responded to the medicine and surgery. And to think that someone would have died if you hadn't done something is a big reward. That's the biggest reward of all.
What led to you choosing oncology? We never really talked about that.
Yes, when I was a resident in Baltimore, there was one particular staff person, who did mostly oncology, and I worked very closely with him. So after I graduated from the residency program, I made an effort to go to all the GYN oncology postgraduate programs. The same thing, to me it was a great challenge to treat a patient with cancer. And he was the stimulus for it. And in those days, cancer of the cervix, we treated with radiation. And we had our own supply of radium. And we would take the radium and put them in capsules and put them in the patient. And so we had a supply of radium when I came here to Worcester. The Worcester District Medical Society owned a supply of radium. And I was chairman of the cancer committee for a good many years, and it was my responsibility to see that whenever that radium was used, it came back safe and sound. But I had to control who used the radium. I mean, just anybody couldn't come and take it. We had to sort of qualify them that they had the experience and would use it wisely. Because in those days, we'd put the radium in a taxi cab and they'd take the radium out to the hospital. When you look back, it's ridiculous, but that's the way it started. Yeah. There wasn't any such thing as a radiation oncologist. We did everything except the external, but the surgery and technically we did all the radium implants ourselves. And of course now chemotherapy is coming into play in cancer of the cervix. So I'd say that's my biggest satisfaction. Is taking a patient through a malignancy and having her cured. I recently saw the first patient I treated for invasive cancer of the cervix, and it had been 49 years then. And she was treated just with radiation.
Wow. Yeah. Seems like it must be a very emotional specialty.
It is, yes. I remember when I told the husband she had a cancer of the cervix, he passed out on me. Yeah, it is. But, obstetrics is very satisfying. Obstetrics is, entirely different. All your patients are nice and healthy, and very rarely a tragedy occurs. In the mother, of course, in the baby, a lot of things can happen. So the OB/GYN, the obstetrics, is a very happy subspecialty. And then there's gynecology, which is a good surgical discipline, and the GYN oncology, which involves surgery, radiation, chemotherapy, is the unhappy one, the difficult one. I wonder, we now have GYN oncology fellowships. You take 4-year residency in OB/GYN and then 2 or 3 years of a fellowship, and then they go into practice. And I just wonder how many of those young people are going to burn out for a year in and year out to be treating just cancer I think they're going to burn out a lot faster.
Just to take a step back, you mentioned the Worcester District Medical Society held on to the radium.
Mm-hmm.
Why did the Medical Society hold on to a radioactive substance and not the hospital?
Well, each hospital, of course, would have to have a license and had to pass certain qualifications. I don't know what the political setup was. I don't go back far enough to know where that original source of radium came. We eventually sold it, and it was the District Medical Society. It doesn't have anything more to do with it, but I'd say the first 25 years I was in practice, we handled the radium like that. See, each hospital had its own source of radium. I mean, and they only treat maybe a half a dozen patients a year. Certainly economically, it's not feasible. And in those days, there weren't that many even gynecologists that had that much interest in oncology. When I thought about specializing completely in GYN oncology, I just thought to myself, gee, how can I make a living? There aren't that many cases. Now you can see all the cases have come to a central location. Well, I was the only GYN oncologist for a good many years up here at UMass. Now there are 3 full-time GYN oncologists, and they're all busy as can be. You know.
What sort of advice would you have for a medical student or a young physician just beginning to enter the field of medicine?
My advice would be get the very best training that you can get. Don't worry how long it is. Another year or 2 won't make that much difference in the next 25 years. So first, get the best training you can. Secondly, be a good listener. Maybe a good high proportion of your cases you can diagnose just by listening. But I hear that complaint very often now that I've retired and talk with people. The doctor doesn't listen. You know, as soon as the patient says, well, you know, my skin is turning yellow or something, he's made the diagnosis and off he goes. But to listen, and that's what patients complain about, is the doctor doesn't listen to me. Compassion. If you're well-trained and you listen and you're compassionate, you'll never have to worry about getting patients. You'll have the biggest practice you want. That's what it takes, I think. But to be compassionate, you have to put yourself in that patient's place. And when you have a very busy practice, it's awfully easy to just do things automatically instead of giving that patient that compassion that a physician should give them. Those are 3 good principles.
I think so.
Yeah.
Did you see the doctor-patient relationship change over your years of practicing?
Yes, I think it's changing now. There was a closer relationship between the doctor and the patient. Now, the patient comes in the office, and a lot of physicians they have a time to give the patient 15 minutes or 20 minutes or whatever. Patients don't like that. I don't blame them, but that's why we're always behind schedule. If you give the patient the amount of time they need to solve their problem, you can't run a steady schedule, be right on time all the time. So if you give the patient plenty of time, then the patients complain about waiting in your office all the time. But I think that's an important part of the relationship. I mean, if you take the time to sit and talk with the patient and listen, but I think that's disappearing. Not completely, not everybody, but in general, because the practice of medicine has become a business, and you have to think more about the finances of it now than when I started. My uncle said when I started practice, he said, forget about the money aspects of it. Just be a good physician. You won't get rich, but you'll never have to worry financially. So that was my philosophy. I'd never do an operation just thinking about the fee. That would be the worst thing. Should get the finances out of it as much as you can. But of course, the finances are so different now with the HMOs and the insurance companies, and also the income of the physicians is so much greater now than when I came into practice. When I came into practice, a hysterectomy was around $150, $200. Now it's between $1,500 and $2,000. When my son finished his training at Hopkins and came into practice, first day he started practice, he started making more money than I did, because you have with Blue Cross Blue Shield, each doctor has a profile, I guess you'd call it. So my profile said that I charged $500 for a hysterectomy. A new doctor coming in gets his profile set up, and he can start up at $1,000 if he wants. So that's the way that the fees have jumped. But of course, malpractice has increased, the salaries of the secretaries and nurses, the rent. It's all changed. Yeah. You're not going to stop it. The other thing about the young physicians graduating, most of them go get a job. It's not like when I went out, I said, where am I going to practice? I checked around to about a dozen cities and towns around Massachusetts, and then decided that I wanted to come back to Worcester. But today, as soon as they graduate, before they graduate, they go out for interviews, and where they get the most money is where they end up practicing. And after a few years, they get a better offer, and off they go. So that dedication is different. I mean, I wouldn't think any more of leaving Worcester than anything in the world. This is, where I live and where I practice and where my friends are.
I think we need more of that.
Yes, yeah. And I don't know how you teach that.
I think it's difficult. Like we were talking about medical school being so expensive.
Yeah.
If you're in debt $250,000, you need to make a decent salary to pay that off. And if you're just beginning to have a family as well.
Yeah. Well, it took me 5 years to pay off my debt for the loans I had.
But we only have about 3 more minutes left.
Oh, okay.
Is there anything else you'd like to talk about that we haven't touched on?
Well, one thing I might mention is that I've always taught the residents and interns that after you get out and practice, don't tie yourself to a pile of bricks. In other words, you go to a hospital and you practice there, but if you have a patient that has a problem that you don't do often, or don't specialize in, don't hesitate to refer to appropriate physician to the hospital. But a lot of us would get so tied to a pile of bricks, that was our hospital and our lives, and everything could be done there, that you should always think of the patient first. I mean, that patient first, where the hospital is and where the doctor is beside it. I think you'll be successful if you do that. I don't think you'll ever have to worry about a practice.
I think it's important to know your limitations.
Mm.
To know your limitations as to what you know and what you don't know. And to realize when you don't know something, to refer it out.
That's it, yeah. Don't be ashamed to say, to acknowledge that there's some other physician that can do a better job than you can. And that's very important, because that's your ego. You got to get your ego out of your way. Don't let your ego get in the way. It's pretty hard to do sometimes, particularly if you're a specialist in a particular field and you get a case that is rare and somebody else can do better. Refer the case. But it's hard for some physicians to do that. They're very sensitive about that. The other thing that's happening is that physicians are retiring a lot earlier than they used to. I mean, in general, physicians now wouldn't retire. They just keep going until they dropped. But now a lot of physicians will retire at 60, 65, 70.
What do you think's led to that change?
Hmm.
What do you think's led to that change?
What things like?
What's led to physicians retiring early?
Well, I think that a lot of it is the changes in medicine. So some physicians that I know that retired, they were just sick of what was happening between the government and medicine and the relationship with the patients and the hospitals, and they just didn't want to do it anymore, so they retired. I know one of my associates retired at 56, two of them retired at 56, and that's awfully young for a doctor to retire. But that's happening more and more. They're going from medicine into business. And one of the reasons, of course, is monetary. I don't see that changing in the near future. I don't know how we can teach that in medical school. You know, we teach the residents, and they're just terrific when they're in residency, but once they step out into private practice,